Assalamu alaikum. It's clear. Thanks, Mr. Chairman, for the nice introduction, and thanks SSBMT and SSH for the invitation. So in the next 20 minutes, I'm gonna talk about CAR T cell versus bispecific. We know CAR T cells available in Saudi Arabia, bispecific also available. So what are the data behind the outcome and the efficacy of this therapy, and which patient is fit which type of the therapy? So let's start by this case. So this is typical 33-year-old female actually diagnosed to have stage 4 diffuse large B-cell lymphoma, bulky, and this is actually was in 2018. So she received actually standard therapy R-CHOP 3 cycles. At that time, she achieved partial remission based on the CT criteria. And unfortunately, after cycle 5, she started to have some fever, short breath. CT showed increase in the mass, so it's labeled as primary refractory. At that time, we don't have CAR T cell, we didn't have CAR T cell, so she received the standard 2 cycle of Arisha. She achieved partial response, and she was underwent autologous stem cell transplant. Unfortunately, before even day 100, actually, she presented fever, short breath, even before the disease assessment, and CT showed progressive disease. So she was admitted to ICU with sepsis and passed away secondary to her disease. So what we learned from this case, actually, we know that based on the scholar, that any primary refractory or early relapse actually carry poor prognosis with median overall survival around 7 months. So how can we improve that? So one of the solutions is to have CAR T cell. So there is a CD19 directed CAR T cell. As you know, this is actually, it's contain of CD19 binding domain and co-stimulatory domain. Basically, you collect the lymphocyte, insert viral vector, leads to the expansion of the lymphocyte and doing manufacturing, then reinfuse the cells again. So this is the journey of the CAR T cell. So you will do leukapheresis, collect the lymphocyte, do the insert the viral vector, and the manufacturing time usually takes around 3 to 5 weeks until the product ready, then reinfuse it to the patient again. So this is another case of 55-year-old female diagnosed to have marginal zone lymphoma 2019, then transformed to large B-cell lymphoma in 2021. She received 6-cycle R-CHOP, achieved remission, and actually after radiation showed complete metabolic response. Unfortunately, after that, she relapsed less than 2 years with you can see the BET is positive. At that time, also, we didn't have the CAR T cells, so she received the salvage therapy 2 cycles, achieved CMR, so she underwent autologous stem cell transplant in July 2023, then day 100 BET showed complete metabolic response. Later on, around 5 to 6 months, she presented hematuria and right flank pain. CT, as you can see, there is progression of her disease, actually. So she went for a cystoscopy, and biopsy confirmed relapse of her disease. So what the next? Actually, so at that time, actually, we were lucky, and the patient was lucky that we had the CAR T cell in our institution, so we decided to go for CAR T cell. So what the data behind CAR T cell in case of the third line? So actually, in Saudi Arabia, we have 3 products of CAR T cell. We have the Axi-cell, Tisa-cell, and Liso-cell. I will mention here the Axi-cell, which is the Zoma one. Actually, as you can see, the median follow-up around 63 months. And this is actually using CAR T cells as a third line in relapsed refractory diffuse large B-cell lymphoma. And as you can see, overall response rate 83. Here we are talking about this is a third line. So usually these types of patients, we put them palliative. So overall response rate around 83 and median overall survival around 25 months. The second product, which is Liso-cell, unfortunately not available here in Saudi Arabia, also showed positive result around with median follow-up almost 20 months. There is around overall response rate 23 months, with the median overall survival around 27 months. The third product, so this patient actually, she was admitted and underwent CAR T cell. She developed grade 1 actually CRS, no ICANS, and actually febrile neutropenia with multidrug resistant Pseudomonas bacteremia. After actually she was responding to antibiotics, then she was discharged from hospital after 3 weeks. So the aim of this actually graph, just to mention that you can see, so I mentioned about the axis cell is approved third line and the lyso cell. So in the actually TISA cell, it's available. Actually, the first CAR T cell was in Saudi Arabia, was TISA cell. But as you can see here, actually, the overall response rate is less compared to the axis cell and lyso cell. So that's why nobody will use now TISA cell in case of at the third line in case of relapse diffuse B-cell lymphoma. One thing also about, so we know axis cell and lyso cell where both of them are effective. What about toxicity? So you can see this is the axis cell. You can see here we're talking about grade 3 toxicity. So CRS grade 3 or more around 13, neurotoxicity around 28%. TISA cell also they have some toxicity, but as I mentioned, nobody will use it at the third line. Lyso cell, you can see here CRS grade 3 or more is around 2%, with neurotoxicity is around 10%, which is less compared to the axis cell. So this is just to show the bit day 30 for this patient. Here we're talking about third line CAR T cell, fourth line. So bit day 30, you can see complete metabolic response. Bit day 90 continue to be complete metabolic response, and nephrostomy tube was removed. After 6 months, she continued to be in complete metabolic response. So what about this other case? So this is around 70-year actually male. Here we're talking 70-year elderly with diffuse B-cell lymphoma stage 4B. It was negative CNS and bone marrow. Actually, he was fit, like ECOG around 1 to 2. So at that time, he received actually 3 cycles R-CHOP, and you can see interim bit around CMR. And end of therapy, unfortunately, you can see there is progressive disease. So 70-year-old male with primary refractory, usually these types of patients, they are not eligible with autologous transplant. So you used to give them just palliative chemotherapy. But can we, with the CAR T cell, can we improve that? So actually CAR T cell initially was approved a third line, but now we can use a second line. For zomasifin, which is the axis cell product, actually they compare relapse refractory diffuse B-cell lymphoma to receive either axis cell or standard, which is transplant. You can see here that actually the progression-free survival for the axis cell is better compared to the standard CAR T cell. Even also the overall survival is better compared to the standard, which is the stem cell transplant. And not only that, there was subgroup analysis about elderly patients. So as you can see here, it's continued. Those who are more than 70 and receive 70 years old and receive CAR T cell, they do better compared to the standard autologous stem cell transplant, even improve in the actual progression-free survival. What about, so this is about axis cell. What about other two products, TISA cell and lyso cell? So lyso cell also, it was studied in Transform and showed it's approved a second line actually in case of relapse refractory diffuse large B-cell lymphoma. TISA cell, as mentioned, nobody will use a third line, and even the second line, the study was negative. So we have two products approved in the second line, axis cell and lyso cell in case of relapse refractory diffuse large B-cell lymphoma. So we know most of the clinical trial, they is selective in the inclusion criteria. For example, they need the performance ECOG 1 to 2 with good cardiac function, good liver and kidney function. So what about like axis cell data and real world actually? So as a second line. So this actually was studied. So you can see here around like there are they include patients like in Zoma-7. Actually, they are not fit to be, not eligible to be for Zoma-7. So you can see actually they saw actually in this study same result as Zoma-7. So still it's case by case. So even if the patient not fit the inclusion criteria for the Zoma-7, you can use this. You can use CAR T cell with the same excellent result. Also, this was a study actually in real world outcome of lyso cell. In relapse refractory diffuse B-cell lymphoma still showed excellent outcome in the patient actually not eligible to the Transform study itself. This is, so here we're talking, this is actually pilot study, including patient lyso cell, they are transplant ineligible. So transplant ineligible regardless, is because cardiac function or renal function, and actually so they receive lyso cell and still showed excellent result with tolerance They can tolerate it with they can tolerate the toxicity actually in form of CRS and ICANS. But we know CAR T cell is available, but they are barrier actually to access CAR T cell. So one of them actually the availability. So it's, CAR T cells, to have CAR T cell in the institutions needs specific setting. So this is one of the barriers to have CAR T cell. Other barriers also the cost. So it's not actually cheap. And the other barriers actually from referral hospital, like some of them, they delay the patient. They didn't refer the patient till he's sick, not fit for the CAR T cell, and the awareness of the CAR T cell, and other patient factor, because need transportation, the availability of the caregiver. So any alternative? So actually we have like bispecific, which is like CD20, CD30 bispecific. We have two products, the Glofi and IPCO. And actually both of them were actually approved the third line. So glofitamab approved third line, and even IPCO in case of relapse refractory diffuse B-cell lymphoma. Can we use them as a second line? So this is actually the phase 3 STAR-GLO trial. So they actually compare Glofi-GMOX versus R-GMOX in transplant ineligible diffuse large B-cell lymphoma. So here we're talking about second line. So this is actually the study, and the result actually you can see there is improvement in overall survival in the glofitamab group compared to the chemo group in case of transplant ineligible patients. IPCO also, this is also phase 1/2 study actually, so it's also include IPCO with GMOX in transplant eligible diffuse B-cell lymphoma. It still shows benefit in case if the patient is not eligible to the transplant. So now I showed the data about CAR T cell and bispecific. So let's summarize. So CAR T cell is living drug, so it uses autologous T cell, targeted CD19, single infusion, and requirement of lymphodepletion before infusion. One of the issues is the manufacturing time. So once the product is collected, it needs 3 to 5 weeks the products to be ready. Bispecifics off the shelf and ready to be administered. Target bridge between CD20 and CD3 actually, and glofitamab is fixed duration. IPCO continuous until disease progression. No need for lymphodepletion, and it's available, so it doesn't need like high standard infrastructure. So there is no head-to-head comparison between the bispecific and CAR T cell, but if you summarize the data, you can see here actually the overall response rate and CR rate with CAR T cell actually is better if you compare it to the bispecifics, with better overall survival in case of CAR T cell. So this is about efficacy. What about tolerance and toxicity? You can see here CAR T cell actually, we're expecting more CRS, especially grade 3, more ICANS, prolonged cytopenia. Management, some cases, if they develop grade 3 or 4 CRS or ICANS, required ICU admission. Bispecific, you can see CRS grade 3 is less compared to CAR T cell. Even the ICANS, cytopenia is transient. Infection, lower risk of infection, and usually most of the time they're given as outpatients, except in the step-up dosing. So one of the things usually it's important actually for the patients before the physician is the quality of life. Usually you can see a lot in the clinic that you treat the patient, he's in remission, but the patient still doesn't feel that he's back normal. So actually this was looked actually, so the patient who receive actually CAR T cell, you can see initially there is decrease in the quality of life, but with the time it's improved, while those who receive bispecific, it's the opposite actually. So initially quality of life is better, but with time, because there is evidence of chemotherapy, it will decrease. So this is one thing that we have to keep it in our mind. So how do we decide between, if you have a patient, this is for CAR T cell or bispecific actually in second line. So before that, we'll talk about some definitions. So we have triple eligible, double eligible, and single eligible. So triple eligible, these patients are eligible for transplant, CAR T cell, and bispecific. And what the definition of that? So the patient needs to be fit, age less than 70, and with good organ function. double eligible, the eligible CAR T cell and bispecific. So they're not fit like the triple eligible, but they're not frail. And with intermediate actually organ function with good social support. Single eligible, they are actually frail and actually they have some organ dysfunction. You can see here in the double eligible and single eligible, the age is not factors, not like transplant eligible group. So if you have triple eligible group as a second line, relapse refractory diffuse B-cell lymphoma. So the standard, if you have relapse refractory diffuse B-cell lymphoma, is CAR T cell. If you have late relapse, you can consider salvage. If the patient achieves response, you can take them to transplant. But as I mentioned earlier, there's some group, even with their late relapse, they're still transplant ineligible, and we have data still we can use CAR T cell for this group of patients. What about double eligible? Still, if you have primary refractory or early relapse, CAR T cell is the standard of care. If the patient's not fit for the CAR T cell or for any reasons not available, you can use bispecific for this group of patients. Single eligible, so you have this actually glofitamab can be used with or without chemotherapy. So this is actually the NCC in guidelines. You can see actually in case of early relapse, less than 12 months, as I mentioned. So the standard is CAR T cell. If they're not candidate CAR T cell, you can use the bispecific. Late relapse, you can use salvage. Actually, if they achieve remission, you can go transplant. If they're not eligible for transplant, you can consider CAR T cell. Third line, still the standard is CAR T cell, and after that, bispecific. So this is the clinical scenario where the CAR T cell is preferred. So usually patient performance fit, echo up to 2 actually, not up to 1, up to 2 is good function. Disease manageable, so the patients is like, that can tolerate to be off therapy or minimum therapy until the product is ready. High risk feature, actually this prefer CAR T cell, and also access to the CAR T cell and patient preference in case if need only one-time therapy. Bispecific, mainly for frail elderly, rapid disease progression will not able to make it to the CAR T cell, barrier CAR T cell, and after failure of CAR T cell, and preference of the patient in case of the needs to be given as outpatients. So just I'll conclude my presentation about like sequencing of CAR T cell versus bispecific. So I mentioned primary refractory early relapse, standard CAR T cell. If the patient is not fit for CAR T cell, can use bispecific with chemotherapy. Third line, still the CAR T cell is the standard. But here actually in this is actually they looked at the analysis about ABC consortium about the sequence of CAR T cell. So they they look actually to 4 groups of patients. For group 1 and 2, they receive bispecific with or without CAR T cell. Third or fourth group, they receive CAR T cell with or without previous bispecific. And we look actually the first group, which is they receive the bispecific with or without previous exposure, there was a CAR T cell exposure. Actually, there was no difference in the survival. What about the group who received the CAR T cell actually with previous bispecific? Continue, there is no difference in the overall survival with the previous bispecific exposure, but it was noticed actually. The group actually who received CAR T cell with primary refractory, they do worse, even they have bispecific, they receive bispecific. So it's well known, primary refractory is the worst group in case of relapse refractory diffuse large B-cell lymphoma.
2 minutes.
And by that, actually conclude my presentation. Thank you.